We're all ready to roll down?
You're all set, all right?
You're recording.
Okay. Good morning, guys. Give you a little bit of my background. I've been a paramedic for 8 years at Spokane Valley Fire, and fire EMS for 12, almost 13 years old. As a fire certificate for a short time, and then Valley Fire after that. Prior to that, I was a high school teacher for, trying to do the math on that, either 14 or 15 or 16 years, somewhere in there. So my fire career, EMS career started a little later in life, but I like education. To be really honest, I don't like PowerPoints, but I have to use the PowerPoint, I understand that. This is part of the program, but we might get off slide a little bit. I'd love to do this presentation without PowerPoint to say, hey, shut your stuff down. We'll just talk about patient assessment and all that. That's my favorite way to do it. We can just, we get a lot of depth. But anyhow, so, been like I said, high school education, 15 years, we'll say. Coach all that time. Still a coach, high school basketball coach back in time. So, anyhow, that's a little bit about my background. So I can get off script a little bit, so try to help me reel back in, but I like to. Patient assessment is the one thing I feel like in EMS that is very, I think it's more kind of be a good ID starter or innovator or whatever you like a word, innovator. I think it's more important than any of those skills we do. I believe this is what we have to be really good at. And it's where I see, and where I'm really critical of myself, or I'm really critical of other crews, it's where I see us drop the ball a lot, is when we start taking patient history and assessing patients, is we get down and go, wow, I never even touched that patient. I put my hands on that patient. They had difficulty breathing, and I didn't really listen to their lungs. Or they had belly pain, I didn't touch their abdomen. Or I hand them off to, how many of you work in Spokane County? Okay, so I recognize you. Where do you guys work?
AMR.
AMR? AMR? How many AMR? Okay, what other Spokane County we got? D8? Fairway. How many none? I know this guy. Where are you working at? Still down in Colfax? Still in Colfax? Okay. Do we have any Kootenays? Couple. So, Kootenai, you're your own transport, correct? Spokane County, obviously, we know how that system works, and now Whitman County, you're your own transport too. So, this patient handoff thing, when we go through Spokane County, that's where you can, in some ways, I know that there's times when it can be awkward, but that's also at times when you can really self-check and look at your patient assessment skills and go, yeah, the AMR medic asked me if I know A, B, or C on this patient, and I'm going to decide to address that. So it's a really good way. The one thing good about our system, and there's some things that aren't very good about our system, but one of the good things is, yeah, you can really self-check. So my challenge to you, if you stay with AMR and you're taking the patient from me, or from the guy from DA, you're taking the patient from us, is, yes, have our back, follow-up questions, if they're appropriate. Now, you also see, there's people out there that no matter what I hand off to you, you're going to have a question back, even if it's relevant or not. It's almost like you got to get your one in. So anyway, keep that in mind. Patient assessment, this skill sheet. You guys probably look at that and it looks like the devil himself, right? This skill sheet, like there's no way I'm ever going to be able to get this down. Well, I'm going to challenge you with something else. Get this down. Know this. One of the reasons you want to know this is you've had how many tests in this class so far in this program? How many times have you had sat down and taken that? 4? Okay. That feels like 1,000? Okay. So you've seen test questions that were maybe seemed a little bit something, right? Maybe there's more than one right answer in your eyes. Maybe there's no right answer, right? Seen those questions? Well, when you get to the National Registry, you'll see a lot of those, because what the National Registry, I think, will say, when you go to sit down, is choose the best answer. So by putting that statement, that means there might be 4 things on there, A, B, C, and D, that I might do A on scene in real life, and you might do B, and you might do C, and you might do D, and they're all okay, but one's a little bit better than the next, better than the next, and better than the next. So that's why it says choose the best answer. So that's why you want to know this. Because if you know the sequence of this, generally if you know that, okay, A falls up here, and C's down here, then A's the answer. Because a lot of times they'll say choose the best, or what is the next appropriate action. And that's the word you see, next appropriate action. That's where your photographic memory needs to come in. You can pull this out of your brain and go, what's next? Now we all know in the field, if the 3 of us here are working together, and I'm running a clipboard recording information, and she's taking vitals, and he's assessing the patient, that's all happening at the same time, right? It's kind of more of a global thing. But in the National Registry world, it's a linear thing. So when it says, what is the next most appropriate action, in your mind you're going, well, I would have taken vital signs when we walked in the door. But where's vital signs land on this sheet? Way down at the bottom. So even though in your mind, that's where, when you sit down and take that registry exam, when you have to take yourself out of the global real world of EMS, where you and your partner or partners are all doing something at the same time, but you almost have to look at it as you're the Lone Ranger. In that world, then you follow the script. So keep that in mind. That's why you really want to know this sheet. If you know this sheet inside and out, upside down, that's going to really help you with this.
That's the comprehensive normal result physical assessment one.
Oh, that different one than what?
Or not, just the one.
A little bit.
One that's like 3.
It's like 4.
The one Dave's got is the National Registry one you need to know. The one that you've got there, Alex, one we're going to have you guys do here, that goes over the comprehensive one from history to primary assessment to secondary assessment. So it's a full one, so don't worry about that one, Dave.
Not do this one anymore?
No, do that.
I'll do that.
Yeah, that's what we're making them do to
Right.
get more intense.
This says patient assessment management and medical. Thank you. And I have these laying around for EMT basic, advanced EMR. So that brings another thing about this. Here's the importance of assessment. I'm teaching a EMR class right now, which is first responder. I don't know how many hours they have to have. 60? And how many do you guys have? 6,000 or something? So, but anyhow, you know what? Their patient assessment sheet is almost the same. It's basically the same. So, be good at assessment. Get good at assessment now, and while you're still, when you're not able to practice as a paramedic, you're still in EMTA or EMTB or whatever you are. Be good at assessment. Get good at assessment. If you're not able to assess patients because you're with AMR and you show up second and the assessment is supposedly already done by myself or someone else in fire, then if you get there at the same time, if you see me, if you ever see me, you say, hey, can I do this one? By all means, we'll get there and do the assessment. But get good at it, because it's the one thing that I think we really need to be good at. Because at the end of the day, I believe it's about how we deal with people. We're all going to get IVs, we're all going to get IVs, we're all going to miss IVs, we're all going to get intubations, we're going to miss intubations. We're going to make good decisions, bad decisions about medications or whatever. Maybe not, hopefully not bad decisions, but some decisions will make you better than others. But the one thing you want to be solid at, and every time you fall out of bed, you get up in the middle of the night, is this one, the patient assessment. All right, I'm going to skip through this little introduction piece and get right to here. Okay, so this is about a little bit about documentation. Record date and time of physical exam. When we're taking our physical exam, we want to determine the patient's age, sex, race, birthplace, and occupation. And really, we have forms now that basically make us fill this in, right? Either the triplicate copy that we carry in Spokane County. I don't know if you guys still use newspaper. We're trying to get away from it here, but it's a little bit difficult. But all this stuff's right in there as we go. Pain, discomfort, dysfunction that causes patient to request help. General question allows patient to respond freely, the chief complaint. So when you introduce yourself and you ask them, hey, why'd you call 911 or what's going on today, we're probably going to get the chief complaint, right? I'm having a hard time breathing, my chest hurts, my stomach hurts, something. When you are doing a little bit about recording this, when you're doing your report writing, remember, a fall is not a chief complaint. Fall is not a chief complaint. See it all the time. I was going back through cleaning up some of my files. I went through all my run reports from when I was a paramedic student, and I saw it on mine. Chief complaint, fall. Fall is not a chief complaint. MBA, MBC, not a chief complaint. Car accident, not a chief complaint. Neck pain from a car accident, that's your chief complaint. Okay? Here's where I wanted to get to. OPQRST, present problem. This is to me, if you do assessments right now, or you're thinking about doing assessments, you gonna use this or not? Or you're gonna have you want to use this? I hear people go, I don't really like OPQRST. Well, you know what? I bet if we sat and we put you up here and did an assessment, and the rest of us evaluated you, you're probably using a lot of these anyway. But if you're not using it, there's a chance you're getting out of order, and maybe you're dropping the ball somewhere. Maybe not. OPQRST. This is, hopefully, if you can see me do an assessment, I believe I still use OPQRST today. Usually you're going to see me stuck behind a clipboard, so I don't get to do very much of that. It's in the slide by slide. This is where I'll probably get a little bit off slide. But let's just go down these quickly. I don't know anyone's names. There's only a couple name tags out. But let's go right here. What's the onset? What's that mean?
When did the chief complaint start?
Okay. Who agrees? When did it start? I'll pick on you. Okay. Actually, onset. What were you doing when the chief complaint started? What were you doing? What were you doing when it started? So, what are some things? What would be some answers that make your ears perk up, the hair stand up on your neck, or something with onset? So what were you doing when it started? What would be some things that go, ooh, this might be a sick patient? I'll give it a mental. Okay.
Chest pain.
So if I get chest pain and rest, okay, that makes you go versus, yeah, I was out shoveling snow and I got chest pain, or I haven't been in the gym in 6 months, so I decided to start off, get back in it with a 10-mile run. I got chest pain. Okay, so that's a little bit different there. What are some other ones? Wake up from sleep. That's my, I guess if you want to say favorite, that's the one that if somebody gets woke up from sleep with chest pain, is the one I always think about, or difficulty breathing, that's a little bit, maybe has a tendency to be a little more critical. So, yeah, what were you doing? Watching I was watching the Gonzaga game, watching them give up a lead, and my chest started hurting. Or I was arguing with my wife, or whatever, my chest started hurting. I was doing nothing. Nothing can be another one too. When symptoms start, rest, or suddenly rapid onset of difficulty breathing. So I wasn't doing anything, all of a sudden, couldn't breathe, or sudden onset headache. The provocation. What do we have? What's this one?
What causes it to get better? What causes it to get worse?
Okay, does it get better or does it get worse? Okay, how are you going to ask somebody that? How do you want to ask somebody that?
Does it hurt when you touch it? Palpation,
okay.
Sitting or standing position, all those sort of things. Okay. What might bring relief or?
All right, so let's go back to our chest pain again. What are some things that might bring us relief of chest pain? What's that? Nitro. Okay, so to get better, you're going to take this nitro. You get better with that? Yes. No. Nitro without relief. That's another one. Take 3 nitros, no relief. That's the one that always kind of should make the hair stand up a little bit. And again, with our exertional chest pain, so rest, right? I sat down. By the time you guys got here, my pain's better now, so it's gotten better. If shortness of breath, okay, I quit running, it's got better, or it hasn't gotten better. So what makes it better or worse? That positional, Did you take anything? Yeah, I took Pepto. My stomach, it's gotten a little bit better. Or I burped really that hard or something. Q, quality. Now we're getting into the easy ones. What's quality of pain? Again, I'm sorry, I wish I had your name. What's quality of pain? How do you describe it? How do you describe it? Okay? So what could that be? It could be sharp, stabbing, dull, crushing, tearing. Anyone better or worse in our mind, in our world? What's the classic chest pain presentation? Dull, achy, pressure. What about tearing? What's that? Yeah, tearing chest pain, tearing pain, that's always kind of another one that's might be a bad sign. And then R, region of radiation. How do I ask somebody about radiation? Let me give you a hint. Don't ever use the word radiation when you're asking them about radiation. I mean, because I've helped people that are newer students, and they'll, like EMT students who are doing their assessments and all that, and they'll get to this, they're doing their best, they're trying to use it, and they'll get down there and they'll say, do you have any radiation with this pain? Radiation. So, how do we ask that? Yeah, it'll move anywhere. So try to make this into a conversation with your patient. Do you feel that pain going anywhere? And I know the books and everything you read says you can't lead your patients. Sometimes you have to lead your patients a little bit. Especially, you get now, my father's passed away. He died of congestive heart failure. He was young, he was 66, but he had a massive MI when he was younger. But you start asking these questions, and he's going to say, no, I don't have any pain. I have pressure. Okay. And move anywhere? No. But then he also complain that his face hurt or something. So you might have to lead some of these people a little bit. So severity. This is the tough one, right? The old on a scale of 1 to 10 thing. Okay. Well, we could do a little study here. We could all put our hand out on the table, like come around and whack each one of you with a hammer at the same amount of force, and you might call it a 2, and you might call it a 7, and you might say 0, and you might have 10, and you're going to say 12. Right? There's always someone that's going to go higher in the pain scale, which usually means they're faking. No. They say 12 out of 10. No, but that seems to be the way it is. If someone goes really exaggerated and says 12 or 15, a lot of times it means that's not really what it is. But a tough question now, right? Scale 1 to 10. Because everyone's pain scale is different. Why do we want that number? What's that?
To rate how bad their pain is on a scale of what they've felt before.
Yeah, I like it because I can go, we can tell if it's getting better or the way it's better or worse. So, again, we have those people that are going to give it. So if I say, Brian, scale 1 to 10, which, your pain, you say, oh, it's 10 out of 10. Well, in my head, and I'm going to probably say, okay, I'll tell you what, we're going to make that an 8. And the reason I do that is so now if 10 minutes later, Brian's pain is worse, he can say, okay, now it's a 9. And that's what I want to know. I want to know as we're assessing him and treating him, are we getting better, or are we getting worse? If people can't give you one, then I'll give you one. So she says, I don't know, whatever. Say, okay, tell you what, we'll give you a 6. And then you know what they'll usually do? They'll correct you. Say, oh, no, it's not 6. Okay, well, then what is it? But then you'll say, okay, I'll give you a 6. No, okay, it's a 4. But either way, you want to be able to go up or down with that number. That's time, obviously, how long has this been going on. Now, these are the ones where you really become, this is one where when the people that tell me I don't want to use OPQRST, this is my combat to that. They say, no, use it, please. But because I say, well, I got my own questions I want to ask. They go here. So let's think about chest pain for a minute. What would be some associated symptoms of HERT-negative chest pain? What's that? Okay, jaw pain. What are some other things that go together with chest pain? Difficulty breathing. So that could be an associated symptom of HERT-negative. So you have difficulty breathing. What are some other things with chest pain? Okay. How about what the patient's going to tell you? What's that? Arm pain. Arm pain. Weakness. Maybe syncope could be in there. What's that? Yeah, Yeah, nausea, vomiting. Has anyone ever seen a chest pain patient that's nauseated? Vomits? That's my other thing. If someone has chest pain and they throw up, then it's time to go to the hospital immediately, because the next thing you need is compression problems. So. Abdominal pain. What could be some associated symptoms? Vomiting, diarrhea, constipation, those types of things. So this is where you get to ask your other questions. Okay, but this is the one that I would strongly suggest. Get good at it. Wife, girlfriend, husband, boyfriend, significant other. Sit down with them and have them and play patient and ask them these questions. And try to ask them in a nice conversational way. You know, so, hey, I'm Fred. I'm with EMS. What were you doing your chest pain started? Okay, and chest pain's a nice one, because chest pain's where we can do all this. Now, one other thing, and if we have time today, we'll do a little activity with this. Again, I said I used to be a high school teacher, so it's not all about lecture. We're going to have worksheets and color and all that stuff. Not all of these are created equal with every patient. Chest pain's awesome for this, because with chest pain, we can fill in all these blanks. Anything with pain, we can fill in all these. But apply this to a respiratory patient. We can ask them, what were they doing when it started? We can ask them, does anything make it better or worse? That's kind of a tough one. So you get into some of these, it's a little bit harder. Quality, reading, severity. I guess you could put breathing difficulty on a severity scale. Anything like this ever happened before? That's another good one to go in here with this. So I'm going to jump through a lot of these because we just did it. What do we got next? All right, so after we finish our OPQRC, then what are we going into together? Our medical history. What's the other part of that? Sample. Yeah, and if you might want to look at that. OPQRST as the S. And in fact, the National Registry on the EMT one and the EMR one has OPQRST, and then it actually doesn't even have the S. It's an ample. It's the rest of it. So think of that as the S. So again, when you're assessing your patient and you're asking them questions, we want to make it a conversation. So we do our OPQRST. We've asked them all those questions. if you go into that and go, well, what signs and symptoms do you have? You know, what are you talking about? You just ask them all that stuff. So, and again, you can't walk up to your patient and say, hi, what's going on, and what are your signs and symptoms. They're gonna, gonna make this into a conversation. So we do our OPQRC, then we get to our, then we go into the rest of our ample. Allergies. So what allergies are we looking for? What's important to us?
Drug allergies.
Drug allergies primarily, yes. Medication allergies. So again, usually try to follow this script in order. I will jump out of it a little bit with allergies with chest pain. Why would I do that?
They go unconscious. You want to have the allergies.
That's one good reason. Why else do I want that with chest pain? What's something we want to do with chest pain patients? Aspirin. I want to know if they can take aspirin. So it really isn't an allergy question that I ask, but early on will be, is there any reason you can't have aspirin? And then so they can get their aspirin. But so we ask them about allergies. If they say something that they're allergic to, that's something we might be administering them, like aspirin, what would be a good follow-up question after that? What happens when you take aspirin? Because have you ever heard a patient or know of anyone that says they're allergic to something when it's really more of a sensitivity, right? Like, oh, it makes my stomach upset. Okay, well, it's not really an allergy. Or what happens when you get morphine? Oh, I get really woozy. No kidding. Yeah. I had a patient say they were allergic to epinephrine. Good luck. Right? What happens when you take epinephrine? I get my heart goes fast. No way. Okay. So allergies. And then medications, M&P on the sample. I'm going to write these down for my benefit so we stay in order. Try to ask these two questions. You can kind of combine these. So you ask for medications. Now, if you're lucky enough, the person will actually know their medications because they're only on a couple of them. Where it gets tricky is we go to our retirement communities, right? The apartment buildings, and they give you a Shopko bag or a Target bag or a Walmart bag, and it's got like 30 bottles in it, and a few of them are the same, but then there's 30 bottles in it, and you say, what are these for? And they have no idea. So, but that's one way to try to tie these together. So medications, so what medications do you take? And if they say, well, I'm on, you know, lisinopril, okay, what do you take that for? Even though you know it's for the blood pressure, but you try to tie those two together. What medications, and then what do you take it for? That's going to give you a lot of medical history, and then I follow that with, is there any other medical history that's you know, not controlled medication, or take a medication for? Be careful on that past medical history. Again, some of our senior citizens like to tell you about the time they had a broken ankle in 29, putting that fence in, something. So just be careful of that one. But medications, and nowadays it used to be really easy. I thought when I started as a paramedic, medications were pretty easy to know what they were for. But now we got all these fancy names, and they're on commercials. And so I'm like, okay, I know I should know that. Why do I know that from? What was on the commercial watching the football game last night? That's why. But I don't remember, is that for diabetes, or is that for cholesterol, or is that for weak bladder, or what the heck's that even for? But you see these commercials now, so you'll hear these names, and you're not sure. Never be afraid to use a reference either. You know, an app on your phone or something is going to help you with what these medications are for. Past medical history may give us a indication of what's going on. I had a patient last night, 37 days in the hospital for a kidney issue, and just got out, and here he is the next night, so last night, presenting as very ill. So let me see, very ill. Pale, febrile, tachycardic, tachypnic. So past medical history, just got out of hospital for a renal issue. So that's got to maybe lead you to, well, maybe whatever was going on here is not fixed. History, UTI also in there. So, so let that kind of guide you. Also, some other good questions on that. If they've had something, especially again, back to chest pain, and I think chest pain, this is just Dave's bias. We all need to be great at assessing chest pain. That's why we're all here. Probably one of the two reasons, this and trauma, why we're in this room, chest pain. We've got to be good at it. We need to, if they've had an MI before, or they've had something before, another really good question, does this feel like your previous? Yeah, I had an MI in 2012. Does this feel like it did in 2012? Yes. Okay, so either have one again. Last oral intake, my least favorite question in the book. Does it have importance? Sometimes. That's what I mean when I say these questions aren't all created equal. This is what I'm talking about. Last oral intake. Now, what are we looking for here? It might sound elementary, but what are we looking for here? When or what? What's more important to you? When or what? Most time when. You know, and I get our rip sheets back, and we have a lot of BLS captains who maybe haven't had a class on this since they went to EMT school in 1990 something or 80 something. And you'll get your sheet and you're going back and it says last oral intake. And I always kind of laugh at it and it'll say like, ham and cheese omelet. Okay. Or it's soup. All right, well, all right, is that it? Or lunch. Okay, well, lunch in my mind means around 12, but it's more of a when to me than a what. It could be a what. Somebody's got like, really bad abdominal pain, they got what looks like presenting like heartburn. Then you might want to ask, when did you eat last? What was it? Or you find out what it was and it was there at the chili cook-off or whatever. So that might help guide you a little bit. Now the toughest question of them all, or maybe one of the tougher questions, events, the E. Events prior. Tough question to ask. It's really kind of a clunky one to ask. But why do we want that? Why do we want to know what's been going on? First of all, what is it? What is events prior? It's not necessarily what you were doing. That was the O, right? What you were doing. So events prior.
General history.
A little more of a general history. That person that's experiencing sudden difficulty breathing or chest pain, and you might want to find out about stress, stressors, travel. If somebody's really sick, unexplained, you might want to find out whether they just come back from traveling out of the country, something like that. My patient last night, it's kind of his past medical history, but it also is his events prior, 37 days in the hospital. Okay, back to the workout. I just started working out. Now I've got, this back pain that doesn't feel like I didn't get hit. Or maybe I did, but I've got back pain. We're trying to figure out why do I have back pain. And then you start, asking, well, what's been going on this week? What have you been doing here recently? So, like I just took on a remodel, started remodeling a house. So I find myself manipulating my body into positions to do things that I didn't know were possible or two haven't done in a long time. So I might wake up with a soreness somewhere and go, that's weird, why's that? And you're that person that then calls 911, maybe we can help figure that out. That's prior. There are some specific cases where that can really come into play, especially with travel. We can pick up, look at all the geese out on the road right now. I'm sorry. It's not something you see every day. There's a bunch of Canadian geese walking down the road.
It's not turkey.
Can't beat the turkey. I got chased by turkeys in the end.
Really?
I have it on my phone. The beaver was
So what we're gonna, I'm gonna go off script here a little bit. So remember I said we had, I'll put these up here just so. Now we can do ASP. So I said they're not all created equal. So I want you to take out a scratch piece of paper. This is nothing we're turning in. There's no wrong answers to this. This is the beauty of this elective. You get to ask this patient only 3 of these questions. Okay, I'll give you a patient. You ask them 3. I know that I ask probably when those 3. I thought you had your test answer. Genius. So we'll do the first one. Will be this will be a lay-in. This first one will be easy. You have I'll even put him right in the wheelhouse. A 55-year-old male complaining of chest pain. So you only get to ask him 3. 3 total. So really, what I'm saying is, what are, in your assessment, in your mind, what are the 3 most important? And again, yours might be different than his, just 3. So quickly, you got 3 questions.
this guy's gonna collapse on you. You got to ask 3 questions. The beauty of this is no right or wrong. So,
MP count as MP count as one.
no. Yeah, we can count that if you want to. Count that down.
You're one of those guys that argues about every wrong answer. Smart guy.
I must have been right, huh? Okay, what are your 3?
I want to know the onset, possible radiation, allergies, allergies.
Okay. And so with chest pain, you want onset because what do you want to
I
know?
want to know
So active versus non-active.
the reason with radiation allergies, radiation sometimes can be a better indicator, not a better indicator, but a leading indicator for what may actually be going on.
Okay.
Then allergies, when you talk about the aspirin.
Okay. Yep. All right.
Then medical history, case cardiac history.
Okay. Did you have any of the same as him or no?
Yeah, I just I want to know onset, but I want to know medication and different kinds of medical issues. That's new or old.
Okay.
I don't remember how this before I met all the medication.
Who has one that was different than theirs? Did everybody have onset?
It eventually come to an onset, but yes, it does.
Okay.
Be honest as well.
What else? Anything different?
I just said medication. I can figure out passport from medication.
Okay. All right. So this patient has somebody with him because this is a 20-year-old that's unresponsive. So a 20-year-old unconscious. So he has somebody that knows him well with him. So 20-year-old unresponsive. You got 3. This is kind of where this comes into play a little bit more. You have someone that's critical. Asking family or friends, yeah. Someone right next to him. Best friend. Husband, wife, friend. All right, what do we have?
I had onset allergies and medications.
Onset allergy medication.
Oh, you look up my good work.
Okay, so you want to know what was he doing when he went unresponsive? Okay, and then is he allergic to anything? What are you thinking there?
Casey, electric shock.
Okay.
Medication. Taking head wrong.
Okay.
Not thinking that.
What else could medications lead you to? What if one of his medications is Humalog? Diabetic. Yep. Okay. So that's good. Anything else? You guys all have those same three?
That's nice. He said how long has he been down? Was it witnessed or not?
How long? Okay. Okay. Anything else? Last intake and time. Okay. We will. We're going to expand on this here a little bit. We're going to do this. This is a great little activity because it makes you think. And you're really not going to only ask three. And I understand that. That's why I'm doing it, just to make you think a little bit about it. Maybe it's 5 you really want, but did you have that last oral one now? Someone have that one now? 20, here you go, 26-year-old, these are all real patients of mine that I'm pulling out my head. So in my head, in hindsight, I can go back and look at them and know what's going on. These are, you know, and you might see something different. I might give you a description and go, yeah, okay, 26-year-old male. I'm going to give you this part, so I'm going to ask on onset. Sudden onset, difficulty breathing. So 26. What do you think about 26-year-old? Anyone in here 26 or around 26, around that age? Okay, so healthy guy. 20, there he is, right here. Here's our patient. Sudden onset difficulty breathing. So it doesn't look like someone that's sick. So. Okay, what do we know with this guy? What do you got?
Past medical history, allergies,
Oh, good. Yeah. Those are all, you know what? Those were 2 of the 3 that I really needed to know in this person that we actually got kind of a little bit later in the game. So this is a 26-year-old male. Just suddenly couldn't breathe. By the time we found him, he was decreased level of consciousness, loading codes on the gurney, and we ended up not reviving him. He had just got out of the hospital for being treated with a skin infection. Okay, and then we found out he had history of DVT. So what do you think happened to our 26-year-old who suddenly couldn't breathe and died? Pretty likely. Yeah, that's kind of where that leads. So is there anything differently other than running a rapid transport with this patient that could have done for him? Probably not. But so we didn't know any of this information until later. But yeah, those are great. Now we'll throw something else in here as we go along, and that's when we'll start looking at vital signs and assessment tools, and you only get to use 2 or 3 of those. We're going to take a quick break here in just a second. I want to close with one thing with this session, and I apologize. I wasn't familiar with this PowerPoint very well. PowerPoint is supposed to be, in my mind, our visual aids. So that's what they're paid for. Anyhow, with class, you guys are all going to get out of here, hopefully. You're all going to get out of here with a certificate that says course completion, and then you're going to pass the national registry. And that national registry, you're going to sit down on a computer and do that test. It's just going to shut off on you somewhere in the middle. Oh, wait, I got this. Right? Keep it going. And you're going to go home and find out that you passed. When you find out that you passed, you know how you find out you passed? You get an email. It says, congratulations, Samantha. You passed the national registry. That's all it tells you. It doesn't tell you if you passed with a 91 or 98 or 81. It just tells you passed. Or a 71. It just says you passed. So keep keeping that in mind, I know that grades are important. And this is one thing that when I was a teacher that helped push me out of education was testing and grades, testing and grades, testing and grades. Yes, grades are important, but keep this in mind as you go through your until how long are you guys in the classroom?
5 more months.
5 more months. And then you go from there and then you do your clinicals. So keep this in mind as you go through this, to your clinicals, and then on to your ride time. Learn something. Don't let your grades get in the way of learning. Don't let when Gary hands you that test back and you look at it and it says 84 and you know you studied.
Oh, dude, I would celebrate.
Okay, 74. Yes, it says 74 and you really thought you did better than that. Learn from it. You know, you heard the expression, learn from your mistakes. Let's do it. Learn from your mistakes. Make it about learning. Don't make it about a 90% or whatever it is you think you would get. I hated that when I was teaching because every kid, they want to go to college, right? So how do you get to college? Have good grades. Everything became about grades. It didn't become about learning. Make it about learning. As you're learning information, if this guy's killing it, he is doing well. And when he does the labs, he seems to be doing really well in the labs. But back to the classroom, let's say he's doing really well in the classroom and he seems to really get the information. And you say, hey, what do you do to study? And he tells you something. He tells you his strategy. His strategy is to make note cards. I was a big note card guy. Make note cards. Okay, so you go home, you start making note cards. You still don't do any better. Okay, well, you know what? Then that maybe doesn't work for you. So do what works for you when it comes to studying. Or maybe do a little bit. But the other one thing you have to ask yourself is, are you giving it enough time? And are you doing it in the right environment? Some people can study with music. I could have some music on. Overhead light versus big light. There's all these different things about learning and what makes it sink in. Do what works for you. I was never a read the book cover to cover person. I rarely track these books other than as a reference. One of my very best friends at Valley Fire went to med school together. We're going to take our national registry. I use practice tests. That's one of the ways I like to study for that, is a lot of practice questions. By the thousands, literally. When I took my captain's exam, I had like 6,000 different questions that came from the IFSTA officer book. That's when our test was over. So I found everybody's study guide for that, or test bank, or whatever I could find. And that's how I studied it. He, my best friend from medic school, said, what are you going to do to study for the registry? He goes, I'm going to read the book again. First of all, again? I never read it the first time. And then not cover to cover. I don't think, in my opinion, these books aren't meant to be written cover to cover. They are reference books. But just because I say that, don't go home tonight and go, I ain't reading the book anymore because he said I don't need to. Yeah, no, do what works for you. But again, make it about learning. And I say that, so if I'm sitting in the back here evaluating you on an assessment and I'm critical of something, make it about learning. Make it about getting better with it. And I think that's something we can all do at any time. I'd love to go do a weight session with this guy, and I want to learn something from him. I like to lift, but I think if I look at him, he can show me something. What's that? So anyway, but I mean, seriously, make it about learning. Make it about learning. If you miss a question, don't be like, I got that one wrong. Are you kidding me? Make it about why you get it wrong. If you question it, make it because you want to learn why you get it wrong, not because you want your percentage to go up. So ask yourself that. Am I questioning this answer because I want to know the right answer so I know it, or am I questioning it because I want 2 more %? Because if you look at it and go, oh, C, and it should have been, I put C and it should have been B, and I understand why it's B, don't waste everyone's time by going back and fighting for your 2 points. Just move on. Let's take 5.
He's already in prescription.
No, they are.
Now, you're related to Tiger?
Yeah.
Well,
Oh, that's awesome. Yeah, he's, kind of talked us a while, and then he started getting flying. Yeah.
he called. Studying flying last night.
Was he? That's awesome. Yeah, he needs to be in this class. Yeah, he does. He's telling me about it.
I'm spoiled because my driver's a medic, and then I have Tyson, who's like my guy.